for holding the hearing. Thanks for allowing me to participate today. Medicare Part D has been an important addition to the Medicare program, one of the most successful programs, I think, in the history of the Congress. It's a program that my constituents love and something Congress should be proud of. However, I've been concerned about the growing prescription drug problem in the U.S. and within the Medicare program. That's why in 2013, myself and our colleague Ben Ray Lujan first introduced the Medicare Part D Patient Safety and Drug Abuse Prevention Act, which would create a drug management program to prevent physician shopping and pharmacy shopping within the Medicare program. I'm proud that we were able to include it in the 21st Century Cures Bill that we passed last week. It's an important tool to the Medicare program to bring in common sense provision that has been used in Medicaid, TRICARE, and commercial insurance. It also makes reforms to the Medic program in keeping with some of the OIG recommendations. That's the 21st Century Cures Bill. It makes those reforms. The first question is for Ms. Maxwell. In your testimony, you talk about the need for a lock-in program in Medicare Part D to deal with prescription drug abuse and the problem of drug diversion. Do you have any estimate on the size of the problem, how many people and how much money are being lost to prescription drug abuse?
I don't have those specific figures, but I do have the figures in our data brief that the growth in prescribing opioids has been significant. It's been a 156% increase since the beginning of the program, which outpaces the growth in the general program. And so it's a continuing concern. We also have seen a tremendous increase in complaints against Part D, so we have significant concerns about this. We do, as a result, recommend the lock-in, as you mentioned, and I think as we've been talking about different ways to deal with doctor shopping, which can result either in patient harm or the diversion of opioids into the street, one way would be the PDMP to provide access to data around this issue and across state lines, but another way is this lock-in. I mean, it's specifically directed at that issue. Very good, thank you. Dr. Agrawal, I'm sorry if I mispronounced, I just got here. In 2014, CMS issued rules for Part D and stated that they had the authority to remove abusive prescribers from the Medicare program. Can you give me an update on this? How many abusive prescribers have been identified in the Medicare program, and how many prescribers have been removed from the Medicare program?
Sure. So, yes, this is part of our overall approach to extending our enrollment requirements into Part D. So what we've been working on is getting prescribers enrolled. I think I mentioned earlier that there's 400,000 prescribers that have written prescriptions in Part D that we are working to enroll. We are also working to develop exactly the kind of cases that you're identifying. So through proactive data analysis, kind of starting to tee up these cases for the first time. I'm not sure that we've conducted a specific revocation action using only that authority yet. Usually we try to do them in combination, and we may have added that authority to kind of another revocation action, but I can look into whether there's a case that we uniquely utilize that authority.
Thank you. One more question, Mr. Chairman. Ms. Maxwell and Dr. Agrawal, when the medics investigate a case and finish their investigation, I'm assuming that it's automatically referred to DOJ. Is that the case?
I believe they do make referrals. That's part of their requirements.
Okay. If DOJ chooses not to pursue the case, maybe because the view of the fraud is too small to be worth the time, does the information get automatically referred to state and local agencies or state licensing authorities? Can you answer that question?
I'm not aware of that specific mechanism. I do know that we are concerned when law enforcement action doesn't take place, that there are no mechanisms and processes to refer it for recovery of the inappropriate payments.
How about, are the Part D plan sponsors provided updates by the medics? How does the medic work with local authorities and state licensing agencies?
Again, I'm not familiar with the specifics. Perhaps Dr. Agrawal is.
Doctor.
Sure. So the medic, I think this was in the testimony, the medic provided 2,300 referrals to law enforcement over the last, I think it is 5 years. Obviously, we try to refer as much over to law enforcement as we can that we think kind of meets the threshold for law enforcement activity and investigation. Where law enforcement doesn't accept a case, we have a few options. We have shared information with state medical boards to try to get action on their part. We regularly share information with Part D plan sponsors. We do that on a routine basis as well as an ad hoc basis if new issues come up or there are new entities or individuals that become concerning. I think the threshold of our authority currently, there is the, OIG recommendation around recovery of dollars that Ms. Maxwell discussed. I think there are certain limits in our authority that prevent us from going directly to, say, a pharmacy and requesting recovery of those dollars. We do have to work through Part D plans, but there are a variety of avenues to do just that.
Very good. Thank you. Thank you, Doctor. Thank you, Ms. Maxwell. Appreciate it, Mr. Chairman. Appreciate it, and I yield back.
Thank you. The gentleman yields back. I do want to follow up. The committee sent a letter to CMS seeking information about the improper payment rate, and that response is due tomorrow. Will the committee receive that response tomorrow?
We have been working diligently on it. I think you will get the response tomorrow.
Thank you. By the way, you seemed to suggest something earlier that the AC is causing an improper payment rate to rise. Did we misunderstand that?
No, I don't know if this was perhaps your line of questioning. No, what I'd said is that, in the program integrity world, what we see often is that the improper payment rate rises when there are new stringent requirements that providers must meet, whether that's documentation requirements, enrollment requirements, or other. So, for example, the 6.7 rate that we discussed last time in Medicaid is largely driven by providers needing to enroll in Medicaid programs and states having adequate resources and systems to conduct that enrollment activity. I don't think anybody doubts the importance of enrollment. We talked about that as one of the major levers that we are now implementing in Part D that I think will be quite useful. We've already seen its impact in the rest of Medicare. But like any other requirement or standard, it can be hard for providers to keep up, and that can sometimes result in the improper payment rate going up.